All right, everyone, welcome. So, as you get ready to start your clinical clerkships, you're going to find out pretty quickly that real patients don't always read the textbook. Today, we're going to bridge that gap. We'll take everything you've learned about neurology and apply it to a real-world case, so you're truly ready to help patients from day one on the wards.
Okay, so let's just dive right in. I want to introduce you to Mary. She's a 38-year-old executive, and these are her exact words to me in clinic. This quote, "This is why we're here today. A migraine isn't some minor inconvenience. It's a full-blown neurological event." And really understanding Mary's experience is the absolute key to treating the patient, not just the symptom. So before we can even think about what prescription to write, we have to understand the biology. What is actually going on inside Mary's brain during one of these attacks?
Now this molecule right here, CGRP, is a major player in the migraine story. For years, our understanding was fuzzy, but figuring out CGRP's role in transmitting pain signals and causing inflammation, well, it has completely revolutionized how we treat migraine. This is a perfect example of how that basic science stuff you learn leads directly to life-changing treatments you'll be using in just a few months.
You know, when Mary has an attack, she's not just dealing with pain. It's this whole package deal. The headache is on one side, it's throbbing, she gets so nauseous she can't keep anything down. She has to lock herself in a pitch-black, silent room. Even just walking to the bathroom makes the pain 10 times worse. This entire picture is what defines a migraine.
All right, so let's put you in the hot seat. Imagine Mary walks into your clinic, or maybe you see her in the ER. She is in the middle of a brutal, acute migraine. She's in pain, she's miserable, and she's looking at you for help. What are you going to do right now?
We basically have a treatment ladder. You know, for some people with milder attacks, simple things like NSAIDs can work. But for a patient like Mary, whose life is completely derailed by these severe attacks, we have to climb that ladder. We go straight to the migraine-specific agents. And knowing when to make that jump is a crucial decision you'll face all the time.
So this brings us to our first-line specific agents, the triptans. The way they work is actually really elegant. They're serotonin agonists, and they hone in on these specific 5-HT receptors. Activating them basically tells the brainstem and the dura, the outer covering of the brain, to just shut down those pain signals. They're a true cornerstone of acute treatment.
Now here's a super practical point that textbooks can gloss over. It's not enough to just pick a triptan. You have to pick the right way to give it. Think about Mary. She has terrible nausea and vomiting. Is an oral pill going to stay down? Probably not. So you have to think about other options, like a nasal spray, or for the absolute fastest relief, a subcutaneous injection. This is what we mean by patient-centered care.
We've touched on this a few times, but I really want to hammer this point home. For a lot of patients, the nausea is just as awful as the headache itself, sometimes worse. So how do we tackle that? We turn to drugs that block dopamine receptors, like IV metoclopramide. Now here's a clinical pearl for you. These drugs don't just stop the nausea, they actually have their own pain-relieving effect in migraine. And here's a pro tip. If you give these, you might want to give some IV diphenhydramine too. It helps prevent a really uncomfortable side effect called akathisia, which is this awful inner restlessness.
Okay, great. So we've put out the fire, Mary's acute attack is under control, and she's feeling better. But our job is not done, not by a long shot. The real goal is to stop these things from happening so often in the first place. We have to think long-term, about prevention.
So who actually needs a daily preventive medication? Well, the indications are pretty clear. If your patient is having 4 or more headache days a month, or if the attacks, even if they're less frequent, are causing significant disability, meaning they're missing work or can't function, we offer prevention. Mary checks both of those boxes easily.
When you start any of these preventive meds, I want you to sear these 4 principles into your brain. This is your mantra for doing this safely and effectively. Start low, go slow, give the medicine an adequate trial. That means at least 3 months at a good dose. And, this is so important, you have to educate your patient about not overusing their acute meds. So this leads us to the really big question. We have several different classes of drugs that work for prevention. So, which one is the right one for Mary? The secret is to stop looking just at the headache and start looking at the whole patient. This is really where medicine becomes an art. We're not just treating a migraine in isolation, we're looking for other conditions, what we call comorbidities. Can we be smart and find one single medication that can treat 2 of her problems at the same time? That is always the most elegant approach.
Think of this table as your clinical playbook. Let's walk through it.
What if Mary also had high blood pressure? Well, a beta blocker like propranolol would be a fantastic 2-for-1 choice. What if she was also struggling with depression? An antidepressant like amitriptyline could treat both. See how that works? You're using one medication to solve multiple problems, which is just better medicine.
Okay, now before you get too excited about writing prescriptions, we have to talk about safety. Our #1 rule is, first, do no harm. And with migraine meds, there are some really serious issues you absolutely have to be aware of. Okay, listen closely. This is critical. Triptans are vasoconstrictors, meaning they squeeze blood vessels. Because of that, this list shows the absolute non-negotiable reasons you cannot prescribe them. Any history of heart disease or stroke, uncontrolled high blood pressure, certain rare migraine types, it's a definite no. You have to memorize this list. It's a major safety issue. If there is one number I want you to teach every single one of your migraine patients, it's this one: 10. They cannot use their acute triptan medications on more than 10 days in a month. If they go over that limit, they're at huge risk for something called medication overuse headache, where the treatment itself actually starts to cause the problem.
And one last incredibly important safety point, especially for any female patient who could become pregnant. The drug valproate, which can be used for prevention, is a known teratogen. It's absolutely contraindicated in pregnancy because it can cause serious birth defects and has been linked to lower IQs in kids. It's a drug we should avoid for migraine prevention in this population.
So as we wrap up, I really want to bring it all back to this. Yes, of course we want to make the headaches less frequent and less severe. But our real goal, our ultimate goal, is so much bigger than that. It's about restoring function. It's about giving patients like Mary their lives back. So a migraine doesn't put everything on hold anymore. That's how you know you've succeeded.
So, as you head out to the wards, I'm going to leave you with this question to think about. When you're sitting across from your first patient with debilitating migraines, what's the first question you're going to ask them, beyond just their headache symptoms, to help you pick the right preventive therapy? Thinking about that, about them as a whole person, that's what's going to make you a great doctor. Good luck out there.